Hello. Thank you, everybody. Glad to be here. I'm Jennifer Moteleone. I'm from RWJ Barnabas Health. Let's see if I can get this. Yeah, it's not working. I'm the manager of decision support there for the combined medical group. Today we're going to look at integrating complex data sources to meet strategic goals. We'll go over a little bit of background of the organization. We'll look at some of the issues that we had, the resolution that we proposed, how we implemented that, some of the process that we implemented, and then some of the results that we saw. So RWJ Barnabas Health is a 12-hospital system across New Jersey, and we had 7 disparate medical groups come together between 2018 and 2021. And when they first came together, there was limited consolidated professional billing scheduling data. Each of those systems, medical groups, came with their own systems. They all had their own sets of reports, so we weren't able really to look at things across the group as a whole. So some of our initiatives were to normalize the reporting across the entire system, regardless of what EMR system they were using or scheduling system they were using. We want to be able to measure the same key performance indicators and provider productivity across the entire medical group, and understand the organization's referral patterns was one of our big initiatives. We brought in several data sources, including our electronic medical records of Allscripts, Cerner, Epic, IDX, and CHC, along with some other sources, our financial system, which was Axiom, our credentialing system of Simpler, and then our patient satisfaction system, Pressgini. We brought in all types of data, transactional charges, payments, adjustments, which let us do work RVU calculations, our referrals, financials, scheduling data, credentialing data, patient satisfaction data. And one of the biggest issues that we had when the medical groups came together was physician-to-physician referrals. We know that that's an integral part of a health system, and it's tied to many quality programs. We didn't have any of this data available to us. We weren't able to understand those patterns. The referral data was incomplete or didn't exist at all where we did have it. So we needed to bring all of that data in and validate it, which took us a long time to do, and we even were delayed for a little while with some of the validation because there wasn't enough information. So then, in order to get all of the information we needed, we had to come up with a solution, a resolution to that. So we first had to understand really what we needed to bring in, and then after we were able to figure out what data elements to bring in, we had to develop a methodology and a process around gathering that data. We made some fine-tune changes to the source systems around the referral tools, and then we were able to bring all of that system into the single database from all of the different disparate systems into Diver. So we created the process where the practice staff and the providers review the data. We identified 7 reason codes, which were standard across all of the referrals. And we also made a spot for them to add comments, which would give additional information when this referral was incomplete. So we created this process in DivePort In where all of the referrals would be loaded, and then they were able to go in and enter the data twice a month, every 2 weeks, the form would open for them, and they would be able to enter one of the specific reason codes. But this took some training and educating both providers and staff on how to enter the referrals and work in DIVeport. And then we were able to take this information and create reports to track the progress and look for research improvement opportunities. So again, a lot of training went into the staff, both providers and staff were trained on how to enter the referrals in the source system. That was then integrated into Diver, and they were then shown how to go into Diver, and using DIVeport in the referrals would open twice a month on a cycle, and they were to review each individual referral and enter one of the 7 standard referral codes. After the period would close, they were given 5 business days to enter all of that information. When that would close, we would take that information, review everything, and then produce reports. This is a little screenshot on how they would go in and review some of the data and enter it. I'm not sure why it's shaking. And these are some of the referral reason codes that we created to keep it standard across the entire medical group. This way we would come out with standard consistent reports across the entire enterprise. So we would use things like the patient requested this particular referral, or the service is not available in the neighborhood. And then once they were through reviewing all of the referrals, the period would close, and then we were able to develop all kinds of reports in a reporting environment inside of DIVeport. And we were able to do this several different ways. We could do referrals by reason code, referrals by department or region, by specialty. And some of the reports, this screenshot is one of the referrals one of the reports that shows referrals by reason code, by month. Again, we were able to do things by region. Also shows, percentages of referrals. Providers were tracked on how many referrals they were ordering. And then, of course, how many of the referrals were actually maintained in DIVeport. We also could look at things on a department level. This way, each individual practice manager could see how their department was performing. And we can even drill down to provider level to understand each individual provider's referral patterns. Another big thing that we try to look at is our referrals by referral specialty. This enabled management and executives to understand where there might be more opportunity to recruit providers in specific specialties. We were able to look at specific reason codes where we felt there may be opportunity to increase, again, either things that were not available, where we may have the opportunity to recruit things, or understand why, in this case, why patients were looking to use these specialties in other ways. We also have ProDiver capabilities, and we use a lot of ProDiver to create reports as well, to track our goals as well. For senior management, and we have a lot of measures that we built around the referrals. And And we're tracking our utilization by specialty again. Again, this is another one by region. Not sure why this screen is shaking. And then here we've also been able to put in some benchmarks and some targets and show how the individual hospitals are performing against those benchmarks. And then because of the standardization across of the medical groups and the use of Diver, we have been able to see an increase in referrals from inception. So we've definitely seen an increase since the beginning of this process, and we're able to track that. And that's it. So, does anybody have any questions?
Thank you, first of all. Who are the primary users of the information who are responsible for that outcome you just described?
So the referrals are managed by the individual practices along with the providers. They collaborate on entering all of the information. And then the reports are used to senior management for them to make decisions, like I said, maybe to look at where we're missing certain specialties or gaps in our provider care. Yes?
So on these referrals, you get the numbers now. Do you take them, the accounts or anything like that, and go back and see, did they actually, like if you referred someone for a CT scan, do you go back and see, did they indeed have a CT scan within our organization?
So that's something that we were looking to close the loop on, but we don't have that information available to us at this time. Yes?
Demi from Children's National Hospital here.
Hello.
For your Cerner reports that you were able to integrate into Diver, just a quick question. For the automatic push for the reports, what would you say that what would you say that process was like in terms of like IT government, and like how did you face was that limitations? Did you face pushback in integrating your EMR? And if you did, how did you go about it?
Yeah, so with Cerner, we had to create a standard extract coming out of the order, the EMR from the orders. We were able to get that set up. There was, as with anything, a little bit of issue getting the initial extract set up, but we were able to do that, and we get that on a weekly basis. We get the extract in order to import.
Jen,
Yes.
when you did the extract, right, in Cerner, there was some key information that was buried in another column. Was there logic that you had to build?
Yes. So we did have to build some logic, especially with Cerner, for the referrals to be automated in and for reason codes to be assigned where the doctors were picking the appropriate order originally. So that took a lot of coordination on the Cerner side with getting those orders set up, and then on the Diver side, on the Dimensional Insights side, to get that logic created. Go ahead. We have the Dimensional Insights team working with us. Okay, thank you.